Okay, well, this will be a short one. Thank you for tuning in today. My name is Chris Herndon. I'll be conducting the PGY2 Pain and Palliative Care weekly webinar series this morning. And I thought we'd spend a little bit of time talking about medical cannabis, since it seems to be a pretty hot topic these days. And hopefully we'll provide you with kind of a different outlook on the way that this actually is shaping up to be a possible very beneficial tool in our toolbox for our chronic pain patients. So the reason that I am involved in this is because recently we've had an Illinois medical cannabis program that has launched. This pilot program may not be the best one in the country by any means, but it's certainly a step in the right direction. And I think one of the big...
If you want to do that, they can see me.
Uh-oh. If you can, please make sure to mute yourself. Okay, I think that's good. So in Illinois, the way that this works is basically if you have one of the approved conditions, you have to have a physician that you've been under their care, and they sign an attestation basically stating that you have one of the approved conditions. Now, once that occurs, then you have to go through a background check, get fingerprinted, and for a little while, you could not own a firearm. You could not have a FOID card and a medical marijuana card at the same time in the state of Illinois. Missouri has just recently passed their Medical Marijuana Act, and it almost mirrors to the letter the Illinois Act. So this is not necessarily widespread as far as the approved pain-related conditions, but these are the ones that are currently available in Illinois. And each state will dictate their own. The thing that's interesting is that you can actually petition the Board of Medical Marijuana. There's actually like an official government entity that regulates this in Illinois, and then they will consider new or different conditions. These are the states and the current cannabis laws as they sit right now. And as you can see, the dark green, like Washington, Oregon, Colorado, these are the states that have just completely legalized marijuana. So that's recreational and others. Then if you look at the darker blue states, like you'll see Illinois is here, oh good Lord, this must be New Mexico, Arizona. What you wind up seeing is that these are states that have legalized medical marijuana, but they don't stipulate necessarily which cannabinoids are legal, illegal, etc. So there's a lot of differences in the actual medical marijuana laws nationally. So if we talk about the medicinal use of cannabis real briefly, this has been used for quite a long time, up to 10,000 years before the Common Era. And it's named for the Greek word of hemp or cannabis. And the earliest reports that we're able to find probably are somewhere around 3,000 years ago, or 3,000 years, before Christ, when it started to appear within the Chinese pharmacopoeia. The uses were pretty widespread even back then for what they tended to use cannabis for. And we didn't really start to learn what was in cannabis until probably the middle to early 1960s. And that's when they first were able to isolate the THC, or the main psychoactive substance that we actually see as kind of the driving force behind not only the recreational use, but some of the medical use of cannabis that we see today. And the other interesting thing too is that while we had isolated the psychoactive alkaloid of the plant, we didn't really know anything about the receptor that it bound to until the the 1990s. And so, and as research has progressed in this area, we've started to become much more familiar with some of the phytocannabinoids that are available, as well as the receptors that they bind to. And so I'm not going to spend the next 20 minutes or so putting a lot of data out there, but more hopefully provide you with kind of a conceptual picture of how cannabis actually interacts within the nervous system, especially for a patient with pain. So we have 3 different specific kind of primary strains of cannabis that are grown across the world. And the makeup of these strains are very much different in terms of their concentrations of very much, sorry, I'm at home today and I'm getting texts from parents coming to pick up their kids. They're very much different in their concentrations of the different actual cannabinoids that are within them. So for instance, sativa is the most common cannabis strain that we have, and it's relatively easy to grow. It can grow in a host of different climates. And what they'll do is they'll take, for instance, sativa and maybe cross-pollinate it with indica or ruderalis or some of these other strains, and to get hybrid plant strains in which they can either drastically increase one particular cannabinoid or decrease another cannabinoid in order to get what they're actually looking for when they grow these. So these are the actual effects that have been described on the physiologic systems, broken down into system. And you'll notice that most of these are based off of just normal run-of-the-mill strains of cannabis. So they don't break these down into, is this due to this type of phytocannabinoid or that type of phytocannabinoid? And a lot of these are relatively common sense. You have euphoria, you have some of this impairment in memory and ideation. One of the big things that have been popping up more frequently in the literature is this thermoregulatory dysfunction, where patients can actually present with either hypo or hyperthermia to the emergency services. And this usually is in the cases of overdose, by the way. There are a growing number of reports of psychotic breaks when patients or people are using marijuana recreationally. Analgesia is part of it. Anxiolysis is also part of it. And then obviously the appetite stimulation is a big piece of this as well. The big argument right now, I think probably that's going on, at least in our state, is the disruption in psychomotor performance. So if you are using cannabis for medicinal purposes, do you become tolerant to the psychomotor performance or the neurocognitive reaction time? For instance, should somebody who's on medical marijuana be driving? We have a ton of neuropsych data around opioids, but we have very little data around cannabinoid effects on this particular area and what it could mean for somebody operating heavy machinery or doing something along those lines. From a cardiovascular standpoint, you can see some tachycardia and hypotension. That's specifically at the higher doses. There have been reports of bronchodilation and cough suppression, although I'm not sure I would recommend this as a first-line therapy for your asthmatic patients just yet. You can have some peristalsis inhibition in the gastrointestinal system, which can lead to some constipation. The other interesting thing is that a couple of the particular phytocannabinoids that have been isolated actually may have specific anti-inflammatory effects in the GI system. And that's really raised a lot of interest around some of the inflammatory bowel disorders and the use of medical marijuana. It was interesting to me that there are reproductive side effects of cannabis that can involve almost increase in fertility on both sides of the genders. And then obviously we're all familiar with the change in intraocular pressure and the use of medical marijuana for glaucoma. The thing that I think keeps popping up that's very interesting to me is that some of these phytocannabinoids that have been that have been isolated, and we'll talk about those here briefly, really can have a fairly large role in both the general immune system as well as in the neuroimmune system. And there may be some very interesting components of that when we start to think about treating various potentially neuroinflammatory disorders. So of the cannabinoids that are out there, there have been as many as 400 constituents of the plant, and then 66 of these, as of last check, have actually been identified, and the numbers grow frequently. But 66 have been shown to have a cannabinoid structure and possess a similar structural activity relationship binding at some of the various cannabinoid receptors. So I think that the easiest way to break these down is to break them down into groups. So we have the tetrahydrocannabinols, and these typically act as partial agonists. And so, like a real quick and dirty pharmacology review, remember, at any type of receptor, you have a full agonist that actually elicits the full response. You have a partial agonist. You have a neutral antagonist, which just blocks the effect of the receptor. And then you have an inverse agonist that actually creates an opposite effect, but there is a difference between an unoccupied receptor and the occupants of an inverse agonist. So it's important to note that, I think, just as a quick review. So these tetrahydrocannabinols, which do include THC, are considered partial agonists. The cannabidiols, or CBDs, are considered to be inverse agonists. And then three other ones that we're starting to learn a little bit more about in the literature are cannabigarols and their downstream acids and metabolites, cannabinol and cannabinodiol. This starts to get a little tongue twisty there after a bit. And then the cannabinochromines. So those are the main groups or classifications of the known identified cannabinoids. And then we also have two naturally occurring endocannabinoids. And these include anandamide, which is a full agonist, and 2-arachidonedilglycerol. We'll just call it 2-AG from now on. And those are cannabinoids that your body actually makes and actually binds the various cannabinoid receptors. And I think it's interesting to note that we actually have drug development underway right now for a type of pain drug called a FAAH inhibitor, and I'll show you what that is here in a minute, but it's an FAAH inhibitor, and it's basically the same thing as having an endocannabinoid reuptake inhibitor. So it increases the levels in the synapse of these two endocannabinoids and keeps basically the transporter protein from pulling them back in and recycling them. So of the cannabinoid receptors that we have CB1, or cannabinoid receptor 1, we have cannabinoid receptor 2, and then the others that I have listed here kind of have a little bit of a question mark to them. However, we've been able to show that various cannabinoids can actually bind to, occupy, and elicit a response from these receptors. And so I think they're important that we discuss those here as well. CB1, which is definitely the most prevalent of the cannabinoid receptors, have some specific functionality. They're, like I said, they're located in the CNS, and they can have activity in both the cardiovascular and the neurologic systems. They can have involvement in both anxiolysis as well as some analgesia and euphoria. There is there is some discussion about CB1 receptors being present in the gastrointestinal system. Your ligands for CB1 are primarily THC. So the main psychoactive substance in most cannabis strains is the primary ligand for CB1. But cannabinol and cannabidiol can also bind CB1 to a smaller extent. And this is also where dronabinol and nabilone, the two commercially available drugs that we have in the US, also bind. Our second receptor identified is CB2. And this is the one that I think is the most interesting to us in the healthcare community, as specifically in the pain and palliative care community. And CB2, while it is present in the CNS, it is much more highly expressed on immune system cells and the gastrointestinal system. And when you look at where it tends to be expressed in the CNS, we tend to find a nice specificity of CB2s within the microglia and the astrocytes of the nervous system. And that really is interesting to me, specifically when we start talking about some of the central sensitization effects and the roles that the glial cells actually may play in modulating chronic pain. So obviously our function over here, intestinal inflammatory response, and there's also some downstream immune suppression. So there has been some studies done that show that CB2 interaction can also play a role in TNF alpha modulation as well. And your primary CB2 ligand is cannabidiol, or what a lot of folks refer to as CBD. The TRPV receptors, specifically V1, have also shown to host cannabinoids at various points in time and various mechanisms. There is some nociception regulation involved with TRPV1, and also, and probably the limiting factor here, is that there's also some heat regulation associated with specific TRPV receptors as well. And that tends to be what has been limiting drug discovery within this particular class of drugs. And obviously capsaicin is probably our primary ligand, but THC has also been shown to bind here as well. We have a new described cannabinoid receptor that right now is being termed G protein receptor 55. Some researchers are actually calling it CB3, or cannabinoid receptor 3. This is located primarily in the brain and the GI system. We really don't know what it does. We really don't know what happens if you don't have this receptor, but we do know that cannabidiol does play a role in modulating it. So just some interesting things there that I thought would be of interest to you all. So I guess the big question then comes is, well, what happens if you don't have these receptors? So if we can develop knockout animal models of CB1 or CB2, what happens to the animal's behavior, to the sensation associated with typically having one of these receptors? And so if we develop a model where we actually create a knockout mouse of cannabinoid receptor type 1, what we did see, which was kind of interesting, is that these animals had increased mortality, specifically from a time to mortality standpoint. They showed reduced locomotor activity and behavior, and they also had hypoalgesia as based on some of the more common animal model pain tests. And that's kind of counterintuitive, right? Because you think, well, if we're going to give marijuana and marijuana binds at the CB1 receptor, we're hoping that that's got anti-nociceptive effects. This knockout animal model doesn't really match that necessarily. So I think it kind of adds some murkiness to the water here. The CB2 knockout mouse model, what we wound up seeing is that these animals were unable to really mount a strong T cell inhibitory response to certain stimuli, and there also tended to be enhanced inflammatory hypersensitivity based on some of the other stimuli that they presented these models with, or these animals with. To me, this really just raises more questions than answers about the utility of cannabis in the treatment of pain and some of these other associated neurologic problems. So let's talk about the endocannabinoid system real quickly. So if you look at this, the interesting thing about the cannabinoid receptors is that these receptors are actually located on the presynaptic cleft of the neuron. And what you typically will see is that we actually have lipid precursors that create these naturally occurring cannabinoids. Remember, anandamide and what was it, 2-AC, I think it was, and now I can't remember. And these are released, and they actually come up through the cleft and bind here at the cannabinoid receptor of whichever type and elicit their response. So let's see what the actual response is. So this is a little bit more descriptive, and what you see is that these lipid precursors actually will create your endocannabinoids. So here anandamide is shown, and that's probably the more prominent of the endocannabinoids. And what you'll see is that they're released into the cleft, or they actually are pulled back in by this FAAH or FA and broken down to arachidonic acid and recirculated and recreated. So like I said earlier, remember that the FA inhibitors are supposed to allow a longer exposure of CB1 to the endogenous cannabinoid. So what does it do when it actually binds the cannabinoid receptor? Well, we have some changes in adenylate cyclase. We can actually see increased potassium channel conduction. You can see some inhibition on presynaptic calcium channels. And we can also see some effect on the exocytosis of excitatory neurotransmitters. And what's not pictured here too is CB1's effect on sodium channels in the presynaptic terminal. So some really interesting theories about why these particular substances may be beneficial for pain. Another way of looking at this, again, is a little bit better picture of what your CB1 receptor looks like, exocytosis, neurotransmitter, and then downstream binding, okay? And then this is probably the best diagram that we have to show what happens when you have cannabinoid binding at the CB1 receptor and all the downstream specific types of channel modulation that actually occur. And what's interesting here is that we also can see some changes in phosphorylation as well as CAMP and some of the other specific kinases that have been shown to affect peripheral and central sensitization. So if we go back and quickly review what all medical cannabis can actually do from a nervous system standpoint, I think this is the take home as far as what we need to know. There is blockade of the sodium and specifically the PQ calcium channel. There's inwardly rectifying potassium channel modulation. You have sodium channel blockade. You have activation of MAP kinases. You can see some inhibition of mast cell activity. And there's also modulation of not only GABAergic inhibitory systems, but also inhibition of glycinergic and glutamatergic, sorry, not enough coffee yet, neurotransmission. And remember, when we're talking about the NMDA receptor, right, we think of the NMDA receptor as being a depolarization dependent glutamate bound channel. However, remember that you also have to have glycine bind concurrently with glutamate in order for that NMDA receptor to actually open and fire. So some other interesting things that I found when putting this talk together was the effects of some of the different common cannabinoids on cyclooxygenase type 1 and cyclooxygenase type 2. So if you look at THC here and the reference point, the little dotted line on inhibition of COX-1 or COX-2, the reference line is indomethacin. So not necessarily a really common NSAID, but an NSAID that we do use still. And so this gives you some idea of what the cyclooxygenase inhibitory activity of indomethacin is. THC actually has almost a potentiation effect at COX-1 and COX-2. The acid from THC, or tetrahydrocannabinolic acid, I actually got that out, has an inhibitory effect. And interestingly, the inhibitory effect on the COX-1 and COX-2 actually surpasses indomethacin. CBD, which is cannabidiol, another primary phytocannabinoid that we're very interested in pharmacologically, has some inhibition, mild inhibition of COX-1, and actually can potentiate COX-2, at least in this model. However, the thing that's kind of missing here is that where are they measuring the COX activity? Is it from blood? Is it from various tissues? And remember that CBD or cannabidiol can be very active at the CB2 receptor, which is predominantly located in the gastrointestinal system and in the immune system. Here we have CBDA, or this is going to be a tough one, cannabidiolic acid, and this is actually CBD's acid. So we have CBD activity here, but then once it's converted to CBDA, then we see a very pronounced effect at COX-1 and COX-2. And then you can see some of the other common cannabinoids listed down here. And then this just shows you percent inhibition versus concentration in the curves that you can actually see. Okay, and there is obviously some plateau of the effect as you get higher with some of these cannabinoids, but others do not appear to have as potent of an effect. So this brings us to some guidelines that came out a couple years ago. This is from the American Academy of Neurology, and this was a really nice systematic review looking at medical marijuana and some neurologic disorders, including pain. And I thought this was interesting because this was one of the very first actual major medical organization guidelines or position statements around the efficacy of this class of drugs, for lack of better terminology, in some of these disorders. So what they looked at is they looked at central pain in MS, as well as painful spasticity in MS. And when they pulled these studies together, I thought they did a really good job of looking at oral cannabis as an extract, okay, so like an oil. They looked at smoked THC, which is what a lot of the studies that have been done up to this point have actually focused on. And they actually looked at a drug that's available in the not in the UK, in Canada right now, called nabiximols. And nabiximols is currently being looked at by the FDA here in our country. But what nabiximols actually is it's a 50-50 mix of THC, which, remember, that's the primary psychoactive substance, and CBD, or cannabidiol. And I think that that's a really promising look into where we may be going with all of this. So as far as painful spasticity, all three of them were shown to be effective: nabiximols, smoked THC, and orally administered cannabis extract. When we come down to central pain in MS, the oral cannabis extract appeared to be effective. Smoked THC, it was unclear based on the studies that they had. So they had some positive, some negative. And then nabiximols appeared to be effective. And so this is their basic summary or statement from these guidelines, is that clinicians or patients can consider medical cannabis, depending on specifically what type of cannabinoid is available, for either one of these different opportunities. So I went through and tried to pull up what I found to be reasonable studies. Now, some of these aren't great and certainly wouldn't be considered level A evidence for their use in pain. But these are some of the different areas that have actually been shown to have some utility for medical marijuana or specific cannabinoids in particular. So the one that I thought was potentially the most promising, given our lack of really good modalities for this, is the treatment of the taxane-induced painful neuropathies. There has been some data in medication overuse headache, however, not great data. Cancer pain, I would say, probably has the largest data set for the use of medical marijuana, and also looks to be potentially one of the more promising areas. Neuropathic pain, based on what I showed you and how the cannabinoids actually operate, is probably very promising. And there was actually a study that just came out very recently looking at the use of THC and cannabidiol in neuropathic pain. However, due to Illinois budget cuts, I wasn't able to get full text of that article in time for today's talk. So maybe I'll come back and do a part 2 if you guys don't boo me off the stage. And then some of the other areas. Now, one of the things that I'm very interested in as far as a utility in pain is the use of specifically cannabidiol or CBD in the treatment of fibromyalgia. I think the more that we learn about fibromyalgia, the more that we think this could potentially be not only a disinhibition syndrome, but maybe even a neuroinflammatory disorder, especially at the level of the glial cells. And I think that's been supported in part by the effects of some of the opioid antagonists and their benefit in the treatment of fibromyalgia. And the other area that I think is fairly lacking in actual data, but I think might have some promise for this particular class of substances is in complex regional pain syndrome. And you all on the webinar may be either recommending it or using it or prescribing it in other areas as well, and we can certainly talk about those here in just a second. So these are the commercially available cannabinoids. Obviously, dronabinol has been around for quite some time. That's Marinol. It's the actual THC component, and it's suspended in basically I believe it's a sesame seed oil in the actual capsule because of problems with solubility. Nabilone or the brand name Sesamet, is actually a THC analog. So it's an agonist. It's an actual analog of THC, but it's not actually synthetic THC. We have nabiximols, or as the brand name in Canada is Sativex, and that is the 50-50 THC cannabidiol product. And then we have one that is currently being developed by the same folks that make Sativex, and this is called Epidiolex. And this is straight synthetic cannabidiol. And this is the one that I'm most excited about. I believe that you can get it in a very limited orphan status for some very refractory childhood epilepsies in the U.S., but as of right now, it's next to impossible to get. But the interesting thing is that in some of the states, especially in some of the states that have been, the trendsetters as far as recreational and medical cannabis is concerned, you can actually get CBD or cannabidiol with no problem in a host of different delivery vehicles. And I'll actually share a personal story if you guys don't mind. Oh, excuse me. My mom suffers horrendous Crohn's disease and has had multiple surgeries and resections and has been on every biologic drug and methotrexate and all of the drugs that we typically will use to try to get Crohn's disease under order. And this is a very, timid, reserved, retired military officer's wife that would never even think in a million years of using marijuana to treat her condition. And the last time that I actually went out to Colorado, I kind of talked to her a little bit about, you can use cannabinoids without, getting stoned and driving a VW bus, right? I mean, there is some actual medical utility to these. And we got her card and sent her into one of the dispensaries, the medical dispensaries. And lo and behold, one of these places actually had a cannabidiol or a CBD patch. There was no THC in it. It was a 12-hour patch, and it just had wonderful effects for somebody, that I have more than just a provider-patient relationship with. So I thought this was kind of concerning, based on the big concern of, well, what about kids? What about increasing our kids' risk of actually becoming habitual users and even potentially dependent on the substance? And it's kind of scary because, it's turned into a novelty, especially in the states that have recreational cannabis. And I mean, these look like meal replacement bars and candy and mountain high suckers. I mean, this stuff is really concerning to me because it looks just like candy to kids. And while maybe you are pro or anti-medical cannabis, I think the jury is still out about whether or not exposure to cannabis in the developing brain can actually result in downstream IQ changes and even neurocognitive problems. It's one thing to allow it for, someone my age where I'm already losing neurons, but somebody who's still trying to put all of those pathways in place, that's a little scary. That they do come in drops, and there's sprays that are available, and they do provide a dose. Usually they'll provide a dose of, in terms of percentage of which cannabinoid is actually in there. And because I work in a federally qualified healthcare center, our attorneys have basically said, you guys take federal dollars, we don't want you participating in this, which is a shame. What I do tell patients is if you can get a physician that will provide the attestation in order for you to get your cannabis card here in Illinois, come back and talk to us, and don't just go in and pick, one of these things off the shelf and go for it. But let us try to show you some of the different data about why and how you might want to alter the different percentages of the cannabis that you're actually using. So anyway, this is an interesting review of some of the different cannabis laws that are out there. And this really raised a lot of hype, I believe, over the last 12 months or so. And this was actually a study that was done where they showed that the more lenient or the more open medical cannabis laws are in a particular state, the lower the rate of opioid analgesic overdoses were. And I don't know necessarily that one is causative for the other, but it is a very interesting relationship, I think. So let's argue about this a little bit. Since you guys are all muted, I'll argue with myself, which isn't completely uncommon. I think that if we look at the pro side, it's pretty hard to get into significant trouble when using medical cannabis. I think that the risks of medical cannabis are not as high as some of the other analgesics that we're using these days. There tends to be some really good data in some difficult to treat disorders. And I think that another really unexplored opportunity is the use of some of these products in palliative care or hospice. The other thing that we are tending to see, however the data can be skewed depending on who actually presents it, but we're not seeing the uptick in use of marijuana by kids that everybody was worried about, like in Washington, Oregon, and Colorado, based on making it legalized. The thought was it'd be more available, the kids would be able to get it more readily, and it would cause a lot of problems. And it may be that because it's really no big deal in some of those states, that it's not as cool for the kids to try it. I don't know, but those are just some things to think about. If we jump over to the con side of it, it is still a Schedule I substance based on the DEA in the US at the federal level. So that creates some problems. Even though there has been some legislation that has passed recently that opens the doors for DOD and VA systems to allow their patients to participate in these programs, it's still a little unclear what the liability is for the docs that sign this stuff. I think that there's still, based on the rigor of the data that we ask a drug manufacturer to go through to bring a medication to market, the data is still a little questionable. The other issue that we can see is that this medication can actually be immunosuppressive in some instances, and that we have seen some co-occurring problems with blips in bronchitis. Patients who regularly use cannabis coming in with new diagnoses of bronchitis. There can be a risk of opportunistic problems in those with HIV. And the other argument that I hear from some of my palliative care colleagues sometimes is it's not fair to a terminally ill patient to offer them what they consider to be, voodoo medicine where there's not good data to support what we're doing. So again, I'm not saying I'm on either side, but these are some of the arguments that have been posed based on the folks that are out there. So in conclusion, chronic pain is a problem. If you didn't think so, you wouldn't be on this webinar. There are a lot of multimodal opportunities that we should be exploring. And I think medical cannabis, honestly, is a reasonable way to look at it. On the flip side, though, I think prescribing medical cannabis in and of itself without any kind of direction, discussion, or consideration around what the different cannabinoids are that are represented in a particular substance is really no different than prescribing medical opium and hoping you get a good batch with the right mix of, codeine, morphine, thebaine, whatever the active substances may be in an opium poppy. So that's kind of my soapbox spiel on the way that cannabinoids work and how they should be involved. With that, I will take any questions, if I can figure out how to unmute everybody. Oh, here we go. Let's see if there's a chat thing. Chat. How do you get to chat, Brad? Mute, share, chat. There it is. Okay. So nothing, no comments, questions? Everybody's unmuted right now, so if you have anything, speak up.
Do you think eventually pharmacists should be like dispensing and regulating this? I know it's a touchy topic, but I just wanted your opinion on it, just due to the really complicated like receptors and whatnot.
My personal opinion is yes, but I don't work on the community pharmacy side. If you ask the community pharmacist whether pharmacists should be involved in this, they will vehemently tell you no. And, I guess a lot of it too depends on the federal classification or restriction, the classifying what controlled substance class it's in. There's a lot of pharmacists that are really nervous about, keeping and dispensing a Schedule I substance. And so, there's actually been some discussion around, can pharmacists, a licensed pharmacist, open a dispensary and not get into problems with the DEA from a regulatory or licensure standpoint? A good question. Now, you know that we are working very hard on the Illinois Prescription Drug Monitoring Program board, or whatever you call it, to make sure that as people get these cards and go into the dispensaries, we're trying to make it so that the dispensaries have to submit the actually sale or dispensing of the cannabis to the Illinois Prescription Monitoring Program. How do you guys feel about that? Not our business, or reasonable?
I think that's a great idea. Because it can interact with a lot of the pain meds and stuff, and it's good just knowing what's on. Especially if the dispensaries could indicate like what type of medical marijuana they picked up, whether it be like the patch or the different cannabinoids.
Right. I think that would be tough given all the different types of product that are out there. The way our law is written is that the dispensary has to note the percentage of the different cannabinoid in that product on the label of the product. So they even have to abide by some labeling requirements. And so, but I think that it's, you know, cannabidiol or CBD is so different from THC. I mean, it's almost like, to me, it would be like comparing morphine and loperamide. I mean, they're, I guess, yes, technically they're both opioids, but they're so different and they do such different things. And that may not be a good analogy, but that's kind of what I think of when I think of those two specific cannabinoids. So James has a question, would I use an edible or a smoked product for difficult to control pain? And that's a good question. I don't know that I would ever recommend an edible to a patient, you know, like the brownies or the candy bars or the sodas or whatever. However, I would use the concentrated sublingual oils or drops. And I would probably recommend that over the smoked product, just because of some of the health risks and bronchospasm that can come from smoking cannabis. The other thing that I think we're going to start seeing a huge uptick in is the vaporization of some of these oils. And again, I don't know what the health risks of vaping a cannabinoid oil might be, but I think what we have seen, and I'll kind of jump off topic a little bit. You know, we've done some pretty well-designed studies of dronabinol or Marinol in different pain syndromes, and it's been relatively disappointing. And I think most of the folks that really know this area of research all agree that a lot of the effect of these cannabinoids comes from being able to get them into the CNS in a reasonable amount of time and in a reasonable concentration. So I think the orals, I mean, you still get an effect from those. However, I'm just not sure that we're getting enough CNS penetration and quick enough for it to really prove to be beneficial for some of our more difficult to treat pain syndromes. But good question.
Chris?
Yeah.
So if you were going to use the spray in the medical dispensaries in Illinois, do they actually have some kind of QA or quality control with regards to the actual ratio of THC to cannabidiols?
By law, they are supposed to. However, I don't know who regulates it. Who is the keeper of quality? Now, the Illinois medical marijuana pilot program is actually run through the Department of Public Health. Okay, and then the actual dispensaries and the growers are licensed through our Illinois Department of Professional and Financial Regulation. So, and there's a board, but I don't know who's on this board. And the board is appointed by the governor. And so, you know, and they don't list who's on the board on the website. I mean, it's kind of, you know, no offense to anybody that might be on the line, but it's kind of Chicago politics as usual around all of this stuff. And, you know, you had to come to the table with a really large bag of money to get one of these dispensaries. And they only have so many, and they broke these dispensaries up. This is what's funny to me, but they broke the dispensaries up regionally based on our state police districts. So, you know, you had District 1, District 2, but they followed the state police districts versus population centers. That didn't really answer your question, but
no, I guess just in follow-up to that, I'm thinking if you have a patient that you're going to say, well, if you can get your card before you go to the dispensary, come back to us. Are you thinking about using an oil that would have a very high ratio of cannabidiol to THC then?
That's what I've been telling the patients, yes.
Okay.
And especially for the patients who may be on an opioid already, typically we tell them that, you're going to be much better off if you can at least keep the THC as low as possible. The thing that I question is the research on this stuff, even though it's been going on for a while, is kind of still in its infancy. And it almost reminds me back in the day of when we had figured out that tricyclic antidepressants worked great for neuropathic pain. And then we started to think, well, then selective serotonin reuptake inhibitors should be great. But they kind of fell on their face. And then we thought, well, then that means that it's the norepinephrine. And so, we started looking at norepinephrine reuptake inhibitors, specific, and they didn't do so good. And I'm thinking specifically of the ADD drug. What is it? Atomoxetine? Is that the norepi specific reuptake inhibitor? But, and that had kind of disappointing study results. So it may be the same kind of deal where maybe you do need a little bit of THC in some quantity in order to elicit the benefit and to alleviate some of the suffering that goes along with having a pain condition. But I think that from a neurotransmitter standpoint, I feel like for some of these conditions, the big money is going to be in the non-THC cannabinoids, especially for these inflammatory disorders and disorders that have a pretty prominent central sensitization component to it. But again, I don't claim to be a lead expert. And I have not tried all of these either. Anything else?
So one last question, just to get a better understanding. So you basically get your medical marijuana card and then you go into the dispensary and then you can pick any product that you would like.
You can, and that's unclear based on the law, the law is awful. Basically, the way the law reads is that a person can be in possession of 2.5 ounces of medical marijuana at a time, and you can only get it every 2 weeks. So what if I have a bag full of gummies or the soda pop or, and those are things that we don't know about yet. And we rushed to get this law out. And there was so much partisan bickering around this that I think they missed a lot. And there are no health professional representatives that are, based on their involvement, assigned to this board. There's no Board of Healing Arts representative on the board. There's no Board of Pharmacy appointed representative on the board. So, there's very little understanding other than it works, dude. Trust me,
Yeah, it seems to me it's kind of like equivalent to a physician just writing a prescription for a blood pressure medication and then the patient going and just picking any blood pressure medication that's out there.
That's absolutely the case. Absolutely.
Okay.
There's no difference. In fact, I don't even think it's like that. It's more like the physician writing on a piece of paper, you have blood pressure, and then going to, right? Really.
Yeah, it seems, I think it's a really good concept. I think they just initiated it too early before working out all of the details and really looking at the research.
Right. Okay, 2 quick questions. Brock asks, are there any age restrictions in place in Illinois? The age restriction is 21, at least the last time I looked at the law. And I think that's pretty consistent across the country. Are there others on the call that have medical marijuana and there's age restriction? James, do you have it in Iowa?
No, they've been working on it for a while, but it's far from being a done deal. And I think it really comes down to this issue of who's going to control the medical dispensaries.
Mm-hmm.
I don't think that the State Board of Pharmacy has a lot of interest in that, but there are pharmacists who have, been kind of vocal to say, look, these people are unlicensed. They're not healthcare professionals. We don't know what the quality of the product is.
Mm-hmm.
Some of the smoke product, if it's been sprayed with a fungicide, we've heard of reports of people getting, pulmonary pneumonitis because of what the product was sprayed with.
Right. So Tanya asks, what do you do when they get admitted to the hospital? Everybody has their own policies and procedures, and I've heard of tons of different ones that are out there. Some, if it's an edible or a spray, they'll allow them to bring it in with them. The hospital that I'm associated with, they don't recognize it. If you use it on the outside, even if you have the cannabis card, you're not bringing it in. We're not giving it to you. And most of the physicians are not providing, prescribed Nabilone or Dronabinol for these patients. So I hope that answers your question, but basically we're a no-fly zone when it comes to it. And really, if you look in our county, in our surrounding, Metro East Society over on the other side of St. Louis, there's maybe only 3 or 4 docs that have registered on the site as taking patients for medical marijuana. So it hadn't been a huge uptake, at least in our area. Now, that doesn't mean people aren't using it. It just means that they're not going about it legally. And it's very expensive, too. Obviously, nobody's covering this. I don't think this is something we're going to see Express Scripts step up and put on their formulary anytime soon. And I'm being told that the medical grade stuff, the 2.5 ounce, can be several $100s, which I guess is much more expensive than, buying it from Frank on the street corner. I mean, I don't know what marijuana costs, but I don't think it's that expensive. Lacey, does anyone on the call have experience with starting it in hospice patients for symptom management? We just talked about this recently, I think. Brad and I did. And I'll tell you that I have quite a few, over the years, have had quite a few palliative patients or hospice appropriate patients that we have taught how to use it without actually giving it to them. I think it'd be a pretty big strain on a hospice's formulary budget to try to get into this business. But then, on the flip side, there's quite a few patients out there that have chosen their drug over our drug in our chronic pain population and feel like they do much better spending the money on cannabis than they do on a expensive long-acting opioid. So I don't know. I mean, that doesn't answer your question. I'll be quiet and see if anyone else has experience.
Hey, this is Lacey. Yeah, my question, I'm from Ohio, and so recently we had it approved, and our palliative and hospice physicians are starting to discuss, whether it'd be appropriate or not. And definitely formulary and cost and all of that is being discussed. But with it not being approved at the federal level, would that kind of be a caveat that we would not cover it for our Medicare patients because of the CMS if it's not a federally approved drug? Any thoughts?
I think you're kicking the hornet's nest.
Yeah.
At least at this point. I mean, several years ago, what was his name? Eric Holder, the Attorney General, basically came out and said, it's still Schedule 1, but we're not going to mess with you. We're not going to mess with the states. We're not going to screw around with, any of this stuff. If it's legal in your state, do what you need to do. I mean, that's kind of the gist of it. I don't know if you guys remember that or not. But, it still leaves some question in the back of your mind, what let's say the new president decides that that's not what his attorney general or her attorney general is going to believe, then I mean, yeah, I mean, you could put a policy into place that comes back and bites you pretty quick. So I don't know. I mean, and we get into the whole, if you really want it, I know some of you probably got to jump off because we're at an hour, but the thing that is interesting to me is how a state law can usurp a federal. I mean, I know it's not a law, but how a schedule of a drug can affect, usurp or go against a more stringent federal classification. I think this is crazy, but it's here. We got to deal with it, and our patients are using it. And what I think we can do as healthcare professionals that are interested in pain and palliative care, we may not be able to buy it for them or pay for it, but we may be able to help them make educated decisions about what they use and help them achieve a better quality of life. So that'll be my closing statement. Please vote for me. Anybody else? Okay. Well, thank you very much for tuning in. It was fun. Sorry that it was a little slow going in the beginning, but as my coffee level increases, I think that we had some good discussion. So I will post the link to this up on the Society of Palliative Care Pharmacists members portal. And we, as a reminder, we will not be having the webinar next week, as everybody will be at the Midwest Pain Society meeting. So thanks again, and we'll talk to you soon. Have a wonderful weekend.